Okay, we'll talk a little bit about skeletal pathology, and we've got a big long list of things that we're going to be looking at here. So we'll briefly review anatomy and physiology of the skeletal system, particularly different types of joints and things like that. We'll detail the occurrence, signs, symptoms, diagnosis, treatment of the following pathology: OI or Osteogenisis Imperfecta, Achondroplasia, Osteopetrosis, hand and foot malformations, vertebral and cranial anomalies, osteomyelitis, various arthritises, that's a very broad term, ankylosing spondylitis, injury to the vertebral column, which we pretty much already discussed in the last lecture, but we'll just do a quick recap of that, and then benign versus malignant neoplasms. So I've shortened some of the considerations for this chapter down to just those things that I imagined would be most likely to be seen in general x-ray, right? And we'll also discuss very briefly radiographic technique required for these different pathologies. So the human skeletal system has 106 separate bones, 126 bones in the appendicular skeleton and 80 bones in the axial skeleton. Most commonly they're composed of calcium and phosphate with a few other things thrown in there. And their main function is support, protection, movement, and blood cell production. So bone marrow, red bone marrow is a significant part of where our blood comes from. So in terms of looking at the bone, we have a compact outer portion, sometimes just called compact bone, and the cancellous bone within that inner portion. Oftentimes on x-ray, the cancellous bone appears as what we call trabecular patterns on the x-ray, and it's a sign that we have sufficient technique to view what we need to view. There's a medullary canal within the longer bones, which is where the red blood cells are. It contains the yellow marrow. And then there's that trabecular pattern there. Particularly, we can see it on this image around the head of the bone. The diploe, someone remind me, what does that mean? Cancellous bone located within the skull. So the hard bone, no wait, the inner portion of the bone within the skull. Diploe. Cancellous bone of the skull. And then that red bone marrow within the long bones of the body. So bone cells are largely defined as osteoblasts, which are those bone-forming cells which line the medullary canal. They're kind of interspersed, and so we talked about them helping with fracture repair. And then osteoclasts are specialized bones that are used to break down the bone, right? Specialized cells used to break down the bone, largely to enlarge the medullary cavity. There's different types of bone classifications. I'm not necessarily interested in that for our purposes here, but we do need to be able to identify these different areas of ossification as being the diaphysis, which a lot of times I think about as the main shaft of the bone is the diaphysis. The epiphysis, so we talk about the epiphyseal plates, right? These areas of additional growth. And then metaphysis. It's not labeled on that, but it's that growth zone between the epiphysis and the diaphysis. The metaphysis. The growth zone between the epiphysis and the diaphysis. In addition to understanding those different types of bones, it's good to have an idea of these different types of joints. And almost all the registry questions that I've seen, there's at least one question in there about the joints. So I've got some really basic definitions of joints here, but Fibrous or synarthrodial, which means it doesn't move. Synarthrodial means without movement. So sutures of the skull are a classic example of that. Cartilaginous or cartilaginous or amphiarthrodial means that it moves slightly but not that much. So moves slightly but not that much, and an example of that is the intervertebral joint spaces. They don't move that much, and we wouldn't want them to move that much. And the synovial or diarthrodial, those do move. They're the movable joints like the knee. So fibrous, cartilaginous, synovial, or if we want to get fancy, synarthrodial, amphiarthrodial, or diarthrodial. Probably totally mispronouncing that. Okay, the first disorder that we'll talk about is osteogenesis imperfecta, sometimes called brittle bone disease. This is mutations in the gene. You don't necessarily need to know where those mutations occur, but there's two different forms of this disease. One is osteogenesis congenita, which is apparent at birth, and it leads to deformity and often early death, versus osteogenesis tarda, which just means later or slower. This starts some years after birth, so the fracture generally stops at adulthood. Has anyone had a chance to do images like this? This is osteogenesis imperfecta tarda. Campbell's Clinic is a place where people are treated for disorders like this. And so again, genetic, congenital disorder. Oftentimes, if it's apparent at birth, we're going to call it congenita. If it occurs 5 to 15 years of age, we're going to call it tarda. And I want to share this with y'all real quick because Kid President is someone who has osteogenesis imperfecta. Has anyone seen his videos? I think he's really cool and a very interesting guy. So I'm just going to share some of his video with y'all real quick. Yeah, I wish they could bottle that energy up and share it. All right, continuing on with the congenital and hereditary diseases, achondroplasia is a bone deformity and sometimes called dwarfism, right? It's the most common inherited disorder. It is recessive in nature, so you could have two siblings, two brothers, for example. One of them has it manifest, and the other one it's latent, it's not apparent. So the treatments related to it largely have to do with stabilizing the individual, making sure that they're not outpacing themselves in terms of the bone growth and distribution of weight and stuff like that. Here's some evidences of it that we'd see on X-ray. And our textbook talks about how this bone age that's done here on the left shows this kind of abnormal flaring appearance at the metaphysis. So within the growth space between the epiphysis and the diaphysis of the fingers, we see a flare, kind of almost like trumpet shape. And the phalanges themselves are broader, right? So they're wider. Another thing that this CT image shows us is called mid-face hypoplasia, which just means that the skull has continued to grow, but the facial bones have not, right? So it is a characteristic of achondroplasia that the skull would continue to grow because the brain still needs that space, right? But it has outpaced the growth of the face. And so an example of that is Peter Dinklage, the actor who's in Game of Thrones. He has achondroplasia. He's made videos about his thoughts on it. But rather than show y'all a video about his thoughts on achondroplasia, I want y'all just to see him interacting with someone, just an interviewer, just so you get a feeling for what are his everyday kinds of thoughts that he has. Again, my point with showing you these videos is just to underscore the fact that as we look at these congenital deformities and things like that, every day of this person's life is shaped by this, but it doesn't have to shape our interactions with them, right? And they can still be a tremendous blessing. They have their own perspective on things. And I think that treating them as a human being, as an equal, is going to just be very refreshing for some of them, right? And it may be something that I thought was interesting. Towards the beginning of his interview, he says, "Are you nervous?" Right? And the interviewer did seem nervous to me, right? And I'm sure it's something that he's watching those cues constantly. Like, am I making this person feel nervous right now? And that's part of his life. All right, osteopetrosis, which, if you remember, in the middle of it, so it says osteo, that means bone. Petrosis comes from the, I can't remember if it's Latin or Greek word for rock, right? So like Peter's name means rock, and Christ says, on this rock I will build my church, right? So right there inside this, it's telling us this is marble bone, or sometimes called stone bone. It means that there's an increased increased bone density and defect in bone contour. And the bones are heavy, but they're also more brittle, right? So they're more dense. This will require increased radiographic technique, right? And this is a classic example of one of these congenital diseases that's commonly asked registry questions about, because it's both a medical terminology question and also a radiographic technique type question. But if you're wondering about what the density is, I mean, these almost look bright white on this image. We can't see any trabecular pattern because it's been annihilated by the density of the bone. But we also do see these contour deformities where the bone is of a different shape than what we would typically expect. Hand and foot malformations. I've only included one of them on here, but the ones that are of interest to us and that we will see examples of in our work are syndactyly, which is failure of the fingers or toes to separate. That means that they have fingers that look more or less like this, and toes as well that look more or less like this. They have not separated. There might be a web-like type material between the digits, right? The bones are not necessarily fused, but the skin around the bones is. Polydactyly means extra digits, and there's certain genetic types out there. One of them I think about in particular, there's a gene strain in Russia where people have 5 fingers, right? And that's part of a gene that's passed down from generation to generation. And clubfoot, which is sometimes also called tallops, it's more common in males than in females. And typically it's just treated with casting and splinting. Of the 3, this one is probably the more registry ready, because there's actual, if you look back in your Merrills, there's actual positioning requirements for tallops. So maybe refresh your memory of how we can assist with imaging of this in order to prepare the casting and the splinting. And if we're looking for someone, I asked Tom if I could mention this. Tom Wolfe was born with this, and it was corrected with casting and splinting. So again, just everyday folks, that struggle with these things, and we could just go about our business. Yes.
Did you mean in Russia they have 6 digits?
Yes.
Because you said 5.
Okay.
And I was going.
I do too.
5.
Yes.
Okay.
Us in America do too. Thank you for your clarification on that.
Well,
Yeah.
When they're born without the digit, they only have 4. Because there's somebody that goes to the school that only has 4.
Yeah, and that's I don't know. I don't know the term for that. I'm not gonna lie. Vertebral anomalies. Let me forward along here. Scoliosis, abnormal lateral curvature of the spine, generally not apparent until adolescence. We work quite a bit with these patients, getting a baseline image and then follow-up images. The incidence is higher in females than males, so it's going to be important that we get appropriate images of this, that we're aware of the radiation that we're using, and that we do things to shield the patient and reduce the number of exposures that we need for any given exam. And also to encourage the patient, because particularly if they're adolescent, that's a key part of someone's development of someone's sense of self. And so we might be one of the few people they can talk to about this, and we might see them from month to month. And so there's opportunities to encourage people there. Transitional vertebra, This is usually at the lumbar sacral juncture. Sometimes we see cervical ribs at C7, and that means just what it is, that there are ribs coming off of C7. Occasionally we see what's called lumbar ribs, where they're like L1 has ribs coming off of the lumbar spine. And the spina bifida is an incomplete closure of the vertebral canal. And again, that's common in the lumbar sacral region. And generally there'll be some kind of outpouching or like a bulge there at the base of the spine. It's apparent without any x-ray. So here's some of those congenital anomalies. We can see there's a lumbar rib right here on this image on the left. So L1 has a little rib coming off of it on either side. Spina bifida, cervical rib, so C7 has an additional rib. This typically needs to be removed surgically because it impairs people's breathing, and the scoliosis.
We had a patient the other day in the ER that had an extra lumbar.
Yeah, and one of the reasons I wanted to include this, I'm glad you said something, is make sure you're counting your vertebra on everyone, because we do have a percentage of the population that have additional vertebra. We have a percentage of the population that have ribs in these transitional vertebra. So continue to count your vertebra on every x-ray that you take of the spine, because these anomalies are fairly common. Okay, continuing on with these congenital anomalies, hereditary diseases, the cranial anomalies. Cranial stenosis is early closure of the cranial sutures, so we can see that on the x-ray above. The sutures have closed, which has caused this irregular formation of the skull now, because the brain still needs to grow even though the sutures have closed. Anencephaly, the brain and cranial vault do not form. This is incompatible with life. So generally this is diagnosed with ultrasound, but we can see here is an x-ray image of a woman late term in pregnancy, and there's a formation of facial bones, but no formation of the skull. Osteomyelitis just means infection of the bone or bone marrow. If it's hematogenesis, that means it occurred at the ends of the long bones. So it happened at the end. A lot of times that's related to things like staph or E. coli infection. We can have contiguous infections, which is a lot of times associated with burns or sinus diseases, or even periodontal infections. So these can get pretty bad pretty quick. So you'll see particularly this, when I think about periodontal infection, I think about if you're working in a hospital that serves people who are under-resourced. A lot of people who come in with tooth abscesses, and now they've got infectious spread to facial bones and things that get really nasty really quick, right? Just started out as a tooth infection, and now we've got infection all through the skull. So that's osteomyelitis. The terms that are helpful to think about in terms of what's happening in the bone as the infection spreads through the bone is the sequestrum, which is an area of dead bone tissue at the center, right? It's devascularized, it's necrotic, the infection has caused the complete destruction of the bone in that sequestrum. Generally it's at the center. It's at the center of it. And then there'll be an involucrum, which is a shell of new bone that's trying to support that area of death, right? So the osteoclasts are going to work to tear out the parts that's diseased and decaying, and this involucrum is formed to continue the structure and the support and the protective purposes of the skeleton around the area of infection. Arthropathies are disorders of the joints. So anything joint related, the umbrella term is arthropathy. So arthritis, bursitis, tendinitis, tensinovitis, these are just inflammations within the joints, either of the tendons or the bursa sac around the joint, and we'll talk more about them here briefly. If it's arthritis, we're talking about joint inflammation. So I want to stress that there's a bunch of different kinds of arthritis out there. So it's going to be important for us to identify what's causing the inflammation of the joint, because that's normally the first word in arthritis. So rheumatoid arthritis, very, very different from other forms of arthritis. So looking at RA, this is a chronic autoimmune disease, and it's generally triggered by some kind of exposure to an antigen. So the body's immune response is triggered, and it starts to attack its own joint spaces. This requires oftentimes some kind of surgical intervention. You can see this one has an idiopathic fracture here as well as subluxation of the first digit. So we see a compounding of problems that are coming out of the rheumatoid arthritis. Incredibly painful, and we also have a reduced life expectancy of about 5 to 7 years for these individuals. If you're wondering what could be worse than rheumatoid arthritis, juvenile rheumatoid arthritis is about as bad as it gets. Still's disease, and there's ACR criterion for this, which is that it's the patient's younger than 16 years of age at onset of disease. We're going to see symptoms of arthritis in one or more joints for at least 3 weeks. Onset of assigned to these different types of arthritis. You don't necessarily need to know these types, but just know that this criteria here is just defining what it is as opposed to rheumatoid arthritis. And specifically, it's happening when people are younger. It's the same autoimmune process, but it's happening with a younger individual. Ankylosing spondylitis, sometimes also called bamboo spine or Marie Strumpel disease. This mainly involves the vertebral column, although as the bone is demineralized, the calcium deposits can wind up in other parts. What we're seeing is demineralization of the spine, and the calcium is going other places, like into ligaments or into joint spaces. So where we see it most acutely is if we missed this here, you'll see bilateral fuzziness of the SI joints. As that calcium exits the spine, it's pooling up and hardening the SI joints, closing off that joint. Also ossification of the ligaments along the spine, and then fusion of the bones themselves. This is treated with NSAIDs and exercise, which is the case with a lot of these inflammatory joint diseases that we're going to look at. Osteoarthritis, sometimes called degenerative joint disease or DJD, is the most common type of arthritis. There's deterioration of the joint cartilage in this instance, in the formation of osteophytes or bone spurs. Gouty arthritis is an inherited metabolic disorder. So I just want to again stress there's all these different types of arthritis. It just means inflammation of the joints. All of these processes are occurring from different directions. Some of them are congenital, some of them are malformations, some of them are just wear and tear and things like that. The gouty arthritis causes an excess deposit of uric acid within the joint space and bone. And one term that's worth familiarizing yourself with is atophy, which is these crystalline deposits as the uric acid crystallizes. We can do serum blood analysis and see that there's this presence of uric acid, but it's difficult sometimes to detect on x-ray. So I wanted to share this image with y'all. This is a very interesting new development in the field. So here's gouty arthritis on a hand x-ray. I cannot see it, right? It looks completely benign to me. The hand, they might say, unremarkable hand x-ray. On typical CT, we have maybe some kind of flare-up or something going on. That might be one of those tophi, or one of those little tiny crystal deposits, right? The uric acid. This is dual energy CT. So with dual energy CT, we can actually do a crystallography, or we can assess the different types of minerals that are deposited in this area. And so you can see the uric acid shows up bright green on this image, and that's a positive sign of gout. So by being able to differentiate different mineral deposit types based on their linear attenuation profiles, dual energy CT shows a lot of promise for the diagnosis of something like gout, right? Which is completely invisible on the x-ray. It would be what we would call a colt. So just future considerations, things to continue to think about as the field progresses. Tendonitis is the inflammation of a tendon. I can't say that one. Can anyone say it? Tenosynovitis, I'll take. Tenosynovitis for 1,000 points. Inflammation of both the tendon and the sheath. The tendon and the sheath. We get the complicated word. Bursitis is inflammation of the bursa, or that sac around the joint space that holds the synovial fluid. And a ganglion is cystic swelling in the tendon sheath. It may not necessarily be in the area of the joint, but it could be. Right? They can be quite painful. When we're looking at the vertebral column, we have some special considerations to think about, like what we talked about with the trauma section. There's these whiplash type injuries, and in general, when we're talking about whiplash, we're talking about soft tissue neck injuries. They can be quite painful. There's not a fracture involved, but the bones were involved in damaging the soft tissue, right? Due to the whiplash action of the spine. Spondylolisthesis is a slipping of the vertebra. It's most typical at L5-S1, and it is sometimes surgically corrected. Spondylolithiasis is an erosion of the vertebral body itself, and this is one of the reasons why we do oblique views of the lumbar spine. If we see that collar on the Scotty dog, not readily apparent on this, I magnified this some, but there'll be a dark line across the Scotty dog's neck. That's indicative of spondylolithiasis, one of the reasons why we do obliques. In terms of neoplastic diseases, I just kind of singled out these 3 benign ones and 3 malignant ones. An osteoma is a dense bone in the skull, so the skull itself just becomes more dense, right? It's benign in nature, and we don't generally surgically resect it or anything like that. Osteochondroma is along the metaphysis of the long bones. Metaphysis of the long bones, right? So we start to see an increased hardening at that point. Giant cell tumor is not as bad as it sounds, although it can occasionally be metastatic or malignant in nature. But there's numerous osteoclastic giant cells, some of which may be malignant. But if you remember from our vocabulary earlier, osteoclastic, that's not good. It means it breaks down bone. So this tumor eats bone, basically. In general, efforts to resect it sometimes are successful, sometimes it crops up somewhere else. The malignant ones, osteosarcoma arises from osteoblasts, and so we have additional very strange looking bones that form out of this tumor. The tumor is actually in the bone. Ewing tumors, this happens between ages 5 and 15, and it's within the medullary canal. And we'll see extensive lesions as it spreads throughout different bones in the body. The most common form of malignant bone cancer, though, is metastases from other sites. So metastatic prostate cancer, metastatic breast cancer, metastatic lung cancer. Bones are a common site of metastases. So they are the most common malignant tumor within the skeleton. And in general, it's the bones containing red marrow that are most often affected, as well as the spine. And for this slide here, for this section, you'll notice we are actually super interested in additive versus subtractive. Every question, for the most part, on the registry that deals with additive or subtractive is interested in the skeletal system, with some exceptions, like we talked about with cirrhosis and stuff like that. But I do feel like this is helpful to just kind of think through this list, use it as a way to refresh your memory of what the pathology was and how that might affect us as X-ray techs in terms of getting patient history and preparing for the examination. Thank you all so much.